Good evening, everybody. It's that time again. It is 5 o'clock on the Gulf Coast, which means 6 o'clock on the East, 4 o'clock in the mountains, and 3 o'clock on the West Coast. It's time for Fertility with Fink and Friends. I am Fink, and you are friends, and it is great to be here like we are every Tuesday evening at this time to talk about all those things that are important to us, things about having a family, things about making a family, things about getting pregnant, staying pregnant, things about women's health, all that stuff, all your questions, everything you want to throw my way. We'll talk about here tonight. I'm here to answer your questions and really to be your source of information on all those things important. Good to see all of you friends. Thanks for joining me here. We've got some different feeds here right in the middle. We've got a couple of different Facebook feeds from New Life Fertility, from MCRM Fertility, from LinkedIn, from YouTube, from First Fertility. Over here is my Instagram page, and that's Randy Fink MD. And here is New Life Fertility's Instagram page right here. I am a fertility gynecologist at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, and in Panama City. Additionally, I work with the fine folks at the Missouri Center for Reproductive Medicine, that's MCRM, in St. Louis and in Tulsa. Happy to talk to you at any of those locations. Yes, indeed, we do virtual consults, and we can talk to you really just about any time. Doesn't matter where you're getting your fertility care. It's the kind of thing that we can talk about no matter where we are and no matter where you are. Let's say a special shout out to all the folks who have joined us here. First of all, a very special good evening to the Bama gal and husband, and that is my mom and dad in Mobile, Alabama, who slept through the program last week, but I won't hold that against you because heaven knows I've caused you enough sleepless nights that you're entitled to take a nap in the afternoon. How about that? Marcella, if you are still here, it's great to see you. You may have moved right along there, but thanks so much. You are actually the first to join here. We've got Katie B doing things. We've got Hannah, and we've got Kowser over here. A special good evening to you, my friends. Oh, we've got several people on the Facebook side of things, but I can't see what your names are, so feel free to tell me hello, and I'll tell you hello right back. And we've got some folks here also on the New Life side, but if you've got some questions, please throw them out my way. By the way, next week is going to be a special edition of Fertility with Fink and Friends, and that is because this, as you may or may not know, is Pride Month. And we're going to talk a little bit about some of the LGBTQ plus options for fertility for those of our friends who would like to join and learn a little bit about that. It is Pride weekend here in Pensacola. And in fact, we at New Life Fertility will be having a presence, a booth down on Pensacola Beach and giving out a little flyer inviting everybody to join next week, next Tuesday at this time for Fertility with Fink and Friends, so we can talk about some of these different options that we offer for LGBTQ plus families. Midgie, good evening, and hello to Tracy in Miami. Thank you for being here. Yes, we ordered the medications. I knew you were going to ask, and we've got Amber over here from Gulf Shores. Good evening, Amber. A beautiful picture of you and your family. Congratulations on all those legal proceedings that are now done, so you can all live under one good name there in Gulf Shores. I got some questions here, and let's see. The first question kind of had to do with a question having to do with morphology of sperm. My husband's semen analysis had a low morphology. Is that a cause of infertility? Well, so morphology means, what does sperm look like under the microscope? I always tell people, and you may have heard me say this before, but we as humans are really pretty inefficient at the way we reproduce. It only takes one sperm to get the job done, right? But in order to reliably put one sperm on target, we need about 20 million sperm in order to get there. And the reasons for that are, well, really kind of twofold. One is that when you look at the way sperm swim, it's normal in a semen analysis to find that that only 40% of the sperm are swimming. And if only 40% of the sperm are swimming, gosh, that means that 60% of the sperm are not swimming. That's one good reason to need 20 million sperm to put one sperm in one egg. But the other reason is because when you look at sperm under the microscope, right? So sperm, they have a head, they have a neck, they have a tail. Somebody's job is to sit at a microscope and look at those heads and necks and tails all day long and to make judgments, to be all judgy about your sperm. Well, what's normal for us is that 96% of our sperm are abnormal. It's normal that only 4% of sperm are normal when you look at that sperm under the microscope. Can you believe that? Hard to imagine, isn't it? But 96% of sperm being abnormal and 60% of sperm sometimes not swimming is a couple of really good reasons why it may take 20 million sperm in order to get there. That morphology issue, which means the way the sperm look under the microscope, is something that can vary depending on who's actually doing the looking. So they say that the reproducibility of that morphology issue may sometimes be questionable. In other words, one very, very skilled and talented andrologist or embryologist can look at sperm and say one thing about what they see under the microscope, while another equally as talented and skilled technician can look under the microscope and call it something completely different. So the reproducibility of one specimen to the other is sometimes questionable. But the second thing is that no, it's not considered to be a cause of infertility, but nevertheless, the presence of abnormal morphology, or that is to say less than 3%, or correction, less than 4% normal forms, is associated with subfertility, meaning to say it's not uncommon that we see that in couples that are having a difficult time getting pregnant. And what does it really mean? It is likely, we believe, a reflection of what's happening in that sperm DNA, or what we know of as DNA fragmentation. DNA fragmentation is when the sperm kind of start to, the DNA, the genetic material in that sperm start to kind of come apart. And when that happens, it's not that that gives you an abnormal baby. What happens there is that the sperm, they get around the egg and they just don't know what they're supposed to do. They say, "Hi, how you doing?" And they don't know that they're supposed to penetrate that egg, that they're supposed to fertilize that egg to go inside the egg and to create an embryo. So sometimes those sperm just kind of hang around. That's what a highly fragmented sperm is likely to do. So we can test for DNA fragmentation. The solution for DNA fragmentation is what is known, ultimately, what's known as ICSI. ICSI is the process of taking one sperm, selecting that one sperm, and placing it inside one egg in order to create an embryo. That's what ICSI is. Now, the other thing that we tell people is that by increasing the frequency of ejaculation, can also improve the quality of the sperm. So it can decrease the sperm count, because with more ejaculation, the sperm count goes down, but the quality of the sperm ultimately can go up. So when you're doing a semen analysis for a test, then we may say, okay, we want you to hold off from ejaculating for 3 days because that's going to maximize the sperm count. But when the time comes to do something like IVF or to provide a specimen for a treatment, we may ask you to increase the frequency of the ejaculation. Let's say that you know that you're going to be doing your IVF on the Friday. Well, I would tell you I want you to ejaculate Wednesday. I want you to ejaculate Thursday, because the specimen for Friday, we only need one sperm for each egg when we're doing ICSI and IVF. That way we know we're going to be probably getting higher quality sperm. There's also some things that our embryologist can tell you we do with sperm in order to help select the better sperm. And that is, and by the way, I will tell you, embryologists are very, very skilled at looking at that sperm under the microscope in order to select the individual sperm. But when you do something like running that sperm through an obstacle course, so that the strongest and the best are the ones that come out the other end first, then that means you're looking at a pool of sperm that are hopefully better, that ultimately will result hopefully in better embryos, because that's the goal. Speaking of which, a special shout out to Jody. Jody, good evening. That is Jody is my wonderful friend in Sarasota, who is an extremely and extraordinarily talented embryologist. And if you are still along, I am very honored that you passed by. In fact, I'd love to have you on the show sometime. If you'd ever like to again. Into Pinot Journey, good evening, my friend. Kauser is asking, with Hashimoto's and thyroid peroxidase antibodies, those are called TPO antibodies, above 600, a positive ANA, and preparing for pregnancy, what would be your top 3 priorities to improve my chances of a healthy pregnancy? And I will say that is an excellent question, because we're talking about the top 3 priorities. Well, so the first thing is that we used to believe that thyroid had to be very tightly controlled, that we wanted, especially in the presence of Hashimoto's or autoimmune thyroiditis, we wanted to make sure that that TSH hormone level was between a 0.5 and a 2.5. And what we know now is that that's not the truth. Now, when I see someone who has a thyroid, that's, in the greater than 3.5, I still feel very apt to want to treat it, because as it's starting to approach the 4 numbers, then I start thinking subclinical hypothyroidism. And I don't like to see that, but that rigorous needing to keep a TSH between 0.5 and 2.5 is no longer something that we know to be true. So the first is with the positive ANA, and an ANA is an anti-nuclear antibody. It's a very non-specific test. It's a test that I use to kind of tell me, well, really, what's your immune system doing? And in fact, I use it. We use 2 tests. I use the thyroid peroxidase antibody as well as anti-thyroglobulin antibodies. And I use the ANA to tell me if the lights are on in the immune system room. It's like standing in the doorway, looking into the room that is the immune system and seeing how many people are milling about, what all is going on in there, because we're trying to see, is your immune system attempting to do something that is trying to keep you from getting pregnant? In the face of that positive ANA, I usually treat you with Plaquenil. Plaquenil is also called hydroxychloroquine. It's 200 milligram capsule twice a day. It takes about 2 months for that to build up in your body, and that can actually take your positive ANA test and turn it negative. There's some evidence that shows us that using hydroxychloroquine or Plaquenil in the face of that positive ANA improves the outcomes with embryo transfers. Normally, in your situation, I would say, you've got a lot of autoimmune stuff going on there. So I would tend to want to use low-dose naltrexone in you as well. Low-dose naltrexone is also a general kind of immune booster. At the same time, it suppresses the bad parts of the immune system while boosting the good parts of the immune system. Low-dose naltrexone has to be made for you. It comes from a compounding pharmacy. So I would think those 2 things are the 2 immune interventions that would be the most important things for me. The third thing I would think about is selecting your best embryo. So we know that if you've tested embryos and you have chromosomally normal embryos, those will give you, on average, about a 65% probability of pregnancy. Otherwise, it's a question of, are you doing a day 5 embryo? Are you doing a day 6 blast? Is it a day 7 blast? Or is it not a blastocyst at all? Is it a day 3 embryo? In which case, you really can't say a whole lot about what that's going to mean in terms of embryo quality. But I would want to select the best embryo for you, because that really makes the most difference about what's going to happen as far as pregnancy outcomes. But a very good question. Our top 3 words of advice there in your situation. Hi to Marin, who is an extremely talented and wonderful um, ultrasound tech who works here at New Life Fertility. Thank you for joining this evening. Looks like Mrs. Kelsey Suggs is here, as is CM Lawrence. Crochet by Crochet is here. Sharmila is here over on the New Life Fertility side. On Facebook, Lana is here, as is Jen. Good evening to you, my friends. Sharmila is over here as well. And oh my goodness, look what happened to Sharmila, who really went through an awful lot to get pregnant before. But Sharmila tells me, I got pregnant naturally and now 5 weeks and 4 days pregnant. Hey, remember, if you didn't know, let me just tell you again, a normal pregnancy is 40 weeks pregnant, which is actually 10 months, not 9 months. So we will always tell you how many weeks pregnant you are, not how many months. And that's the reason why, because 40 weeks is your due date. Now, that due date doesn't mean that's the day the baby's going to come out. Everybody who's been pregnant knows that. But that's statistically the date that we call the EDC, or the estimated date of confinement. That is the time at which you will be confined. We don't confine anybody with pregnancy anymore, but you get the picture, right? 5 weeks and 4 days. Let's see, today is Tuesday, Wednesday, Thursday, Friday. Gosh, so every Friday, Sharmila, you are 1 more week along. I am so happy for you. We are all ecstatic to hear this great news. Over on Facebook, Lana even says, congratulations. And gosh, this is great. Sharmila, I'm not surprised you say you're scared, because you have a low AMH. And with your first pregnancy, during the egg retrieval, we removed 2 polyps. And now you've gotten pregnant naturally. Well, so first thing to know is that AMH level, the anti-Mullerian hormone level, is really just what I would call a surrogate marker. It's a marker for ovarian reserve. It tells me about potentially the number of eggs you have available. It doesn't say anything about your fertility, about your ability to get pregnant, your ability to stay pregnant, and frankly, it doesn't say anything at all about your egg quality either. So a lower AMH just means, it tells me that I have to do a little bit more work if we're going to do something like IVF to try to get your ovaries to produce eggs for us, but doesn't mean anything about not being able to get pregnant. So it looks like the plumbing got plumbed after you had your first baby there, my friend. And that is something that often happens. And I got to tell you, the other interesting thing that seems to happen a lot is that when people come to see me, they've had a workup, they've had a treatment plan, and we're planning to do, some kind of treatment. Maybe it's IUI, maybe it's IVF. Something about seeing the fertility doctor makes people end up with positive pregnancy tests. And I swear to you, I see that every single week here. Somebody comes in and they end up being pregnant just by virtue of the fact that they came to see me. So I think, yes, we are that powerful. Obviously, that's what it is. Or really what I think it probably is that people are trying. And a lot of times we do testing of people's fallopian tubes. And when you do that, it tends to wash out some of the cellular debris that collects in the fallopian tubes that can sometimes block sperm from being able to get through. So people do have an increased probability of pregnancy as a result of doing that test. And I think that's probably one good reason that people often end up pregnant. But however it works, and that part makes me happy. And Sharmila, you are just really just so happy for you. Really excellent. Your baby at home is 10 months along. And you're asking, 10 months only, is it good to carry forward? Not sure what you mean by that, but it is absolutely okay for you to be pregnant now with your 10-month-old at home. When you conceive at like 3 or 4 months, well, that can be a real problem because that does increase the risk of severe preterm delivery. But you will deliver well after your baby is 1 year old. And so the optimum range for having a second child or an additional child is, according to the American Academy of Pediatrics, between 1 and 5 years. And so you will be 1 year, more than 1 year. I will tell you, my two oldest kids, my two boys, are 18 months apart. And it's a very good thing because it means they play with each other, or at least they did. They're a little older now. They're 19 and 18 now. They just try to kill each other. But they would play with each other. They would look for each other. They were constantly at each other. When they weren't trying to kill each other, they were the best of friends. It means that school grades are close, that groups of friends may have some crossover. It means it's a little easier with things like clothing to be able to share. So, Sharmila, I think that's really a fabulous thing, and we are all so happy for you. That is really wonderful news. Hi, Emanuela, it looks like, and Stephanie, good evening to you. Sharmila asks, can I take the Thorne Basic Prenatal and DHA? And I would say yes. Those are the two things that I recommend in pregnancy, and that's the regular prenatal vitamin and DHA or fish oil. You may have heard me say before that if you're taking fish oil, I recommend that you use the one that says that it is odorless or burpless, because fish oil, quite literally, is the oil that comes usually from a sardine. And the first time you burp it up will be the last time you want it to cross your lips, because it can truly be heinous. So odorless or burpless is what you want there, Sharmila, especially early on in pregnancy. You don't want to be burping that stuff up. Is kind of it's a no-go, but that's just really wonderful. Jessica is over here on the Facebook side. Good evening to you, my friend. And I have a question. She says, I went for my baseline testing for an FET and my lining was 9 millimeters. I have to take Provera for 10 days and hopefully have a reset that can be normal for the lining. Can that be normal for the lining to be thicker after 2 months of Lupron? I will tell you that is unusual, because after Lupron, so I guess you had endometriosis or BCL6, and we did some Lupron suppression. And so when you suppress the Lupron, or rather when you suppress the hormones, your estrogen level goes to undetectable, and that estrogen is what causes that lining to grow. So part of me wonders, all right, is there something else growing inside that uterine lining? Like, for example, could there be a polyp? Could there be a fibroid? But I will say also, the measurement of that lining is not perfect by ultrasound. It's not perfect in that some people just look like they have a thick lining. And when we actually do something like put a camera inside a hysteroscope to look at it, it turns out there's really no lining there at all. So what happens when you take some Provera is that it will initiate a bleed for you, and that bleed will be like a period. You will slough off whatever lining is there, and we'll take a look again with the ultrasound to see what your lining looks like. If it's still thick at that point, we'll probably want to take a look inside to see exactly what's going on and to rectify this issue. Is it just an ultrasound finding, or is there actually some tissue growth on the inside? Now, the reason that we want that lining to be thin is because in that embryo transfer cycle, you're going to be growing some lining, right? And so we want that lining to be perfect. We want it to have sloughed off. We want the estrogen that either we're giving you or your body is going to use to grow that lining fresh, so that when your beautiful, perfect embryo goes inside, that your lining is just as beautiful and perfect. And that's really what we're after there. So that's kind of the way that part will go. Hey, to Lauren Lucas, thank you for joining here this evening, and also a shout out. I skipped over. I got so excited about Sharmila's pregnancy, I didn't say good evening to Zenny in and happy Taco Tuesday to you as well in the beautiful southern part of Florida. Happy to have you here. And oh my gosh, I didn't notice also that light skinned Dolly was here. Shay, I would have said something to you right off the bat because I haven't seen you around in a while. I have to tell you, this person, and she's probably already gone here, but this person, Shay, was one of the finest medical assistants that I have ever worked with. She lives in Georgia now. She goes on and does some very wonderful things. She's got some great content online. Lightskin_Dolly is her handle. So follow her as well. She's got interesting things to look at. It's great to see you here this evening. Let's see what else is going on. We are approaching the bottom of the hour, and you know what that means. It is time for the 5:30 Fuzzies with Fink. Almost time for that. Let me ask you this. How are you feeling today? What's going on in your life? Life is, something that throws us curveballs. Life is something that is never predictable, only in that it will be unpredictable. Life is not something that is always friendly to us. And life can leave us feeling frightened. It can leave us feeling lonely. It can leave us feeling like we've made wrong choices and that the future may not work out for us the way we are hoping. In fertility, in particular, it's a very difficult roller coaster to be on. I always tell people, and you've probably heard me say this before, it's the most uncomfortable roller coaster in the entire park. And the reason for that is because you get on it and this thing flips you upside down. This thing jams your head from one side to the other. It shakes you and empties your pockets. God only knows it does that. And ultimately, it pulls back into the station, and you don't know if you're going to be getting off that train with a lovely parting gift, and that's the baby that you got on the train hoping for. We just don't know about those outcomes. And when outcomes are uncertain, it lends itself to anxiety. It lends itself to just not knowing what the future will hold for us. I will tell you that anxiety is something that is hardwired in our brains. It comes to us from way back in our evolutionary days when our brain was constantly monitoring for danger. It's constantly on the lookout for, like I like to say, the saber-toothed tiger jumping from the tree line, or the pterodactyl swooping down to steal our offspring, or the rival tribe coming and clubbing us to death and stealing our food and our women. This was evolution, and evolution was a very hard time. So the brain is constantly monitoring for danger, and that's really what anxiety is. Anxiety is that part of us that is it's that portion of the brain that's trying to justify its own existence and worry about all the possibilities of things that could go wrong. And if you really think about it, 99.9% of those things never go wrong. Only a very small portion of them do. And when we do, and when they do, we deal with those things. But don't let anxiety rule you. Be mindful of what's going on around you. Be mindful of the life you live and of the things that we have really to give thanks about. And that may be for the friends we have around us. That may be for the fortune that we have to drive a car that we like the looks of, or to have a job that we can go to that we enjoy. Whatever it is that is meaningful to you, be thankful for having some meaning in your life. Meaning is what keeps us going. And as we get together now for that 5:30 Fuzzies with Fink, it's the time that we stand together as one community and send the positive vibes out to everyone tonight who needs them. That's folks who are going through fertility concerns and don't know what's going to happen on the other side of the treatment. That's folks who are dealing with family concerns tonight. Maybe it's a sick loved one. Maybe it's someone you're trying to get along with. That has to do with friends and relationships. It has to do with the job and the workplace, all those things that create stress in life and make us feel frightened and alone. Please know you are not alone. And as I ask each of you to send out those positive vibes to all your friends and strangers who need them tonight, know that as a community, we are one. Let's break the internet with kindness. Do kind things for other people. Smile at a stranger. Random acts of kindness make a difference in someone's life. So make a difference tomorrow, will you? And for right now, send out those positive vibes and make a difference to all those people who need to know that they're not alone. And that, my friends, is the 5:30 Fuzzies with Fink. We do it every Tuesday at past when we can all get together and think about things that are really important. Okay, Z says here, recently had ovarian PRP. My AMH is pretty much undetectable, and I'm planning on going for a retrieval. Is there any hope? Will PRP help? So intra-ovarian PRP is platelet-rich plasma. And what we're doing with platelet-rich plasma is taking the portion of your blood that contains your body's healing factors, your tissue factors, your growth factors. It's kind of the most healing salve that your body can make. And we're taking that, we're preparing it in the lab, and we are injecting it into the ovaries. Now, that's considered an experimental treatment. It's not something for which there is evidence to show that it's helpful. Now, in my experience, and I've done 1,000 or more of those cases, I think in some people it does help. In some people, it probably does make some kind of difference. The question is, who are those people? Because when they've studied it now, they've said, well, in the larger population, it's really not making a difference, which tells me, all right, I think it helps some people. It doesn't help other people. And what that says is that we just don't know exactly who those people are that it has the potential to help. So could it help you? Yes, it could. Will it help you? Z, and I would have to say, gosh, I don't know. So, what is the AMH? The AMH, or anti-Mullerian hormone, is a measurement in your blood that comes from the little cells that surround your eggs. So the more eggs you have, the more of these cells you have. And the more of these cells you have, the more AMH you make. So we can measure, since we can't actually count the number of eggs, they're microscopic and they're deep down within the ovary there. Testing the AMH is a surrogate marker for egg reserve. When that number is less than 0.08, that pretty much is what we consider an undetectable AMH. Now, does that mean that you don't have any eggs? No, not necessarily. It means that the recruitable cohort of eggs is going to be very, very low. It means that when we give you stimulation medication to try to get your ovaries to produce those eggs, it's going to be a very tall mountain to climb. It's an uphill battle. The other question that I would want to know there, Z, would be, well, gosh, what was your antral follicle count? So in the beginning of the menstrual cycle, the brain tells the ovaries, give me some eggs. And the ovary says, okay, so it dips down into its well and it pulls up some little egg houses. And these egg houses are follicles. They're literally a little sac of fluid with a microscopic egg in them. So depending on what that number looks like at the beginning of your menstrual cycle, I'd say, well, that's a potential for how many eggs we might be able to recruit in a given cycle. So that number to me would also be important. To be honest, I would not think that intraovarian PRP is going to make a big difference with your egg quantity. The PRP, if used, really the thinking is that it may have more to do with the egg quality. It might, in some people, have the ability to help your body repair some of the age damaged DNA. Now, depending on what your age is how likely that is to happen. So, for example, if you're 48 years old, let's just pick a number there. At 48, I know that the odds of you being able to have a normal egg in that ovary are extremely low. In fact, even at 45, those odds are extremely low. So that doing something like IVF with your own egg becomes, well, a process that is more likely than not to result in disappointment than it is to result in live birth. And the reason for that, it has to do with the stability of the DNA in those eggs. Now, would PRP help in that situation? Well, I think right now the best evidence or the best thoughts is, well, we would like to think it can, but does it really? Well, I think it's probably more helpful to someone, let's say, who's 38, who had a retrieval but had poor egg quality that resulted in poor fertilization, or really just physically the eggs themselves didn't seem to be strong. That's the situation where I think PRP is probably going to be the most helpful. But in terms of arguing with the biology of aging, we're all looking for that magic bullet. We're all looking for that fountain of youth that can make eggs and make us young again. I don't know that intraovarian PRP is that secret. Now, I think that there may be another trick that we have up our sleeves, and that's a medication that's called rapamycin, also known as sirolimus. Now, I have been using sirolimus. Many of us use this. Many of us use sirolimus as an experimental treatment. It's a medication that is designed as an immune modulator. So its goal is, it's commonly used, let's say, in folks who have had an organ transplant, like a kidney transplant. Well, one of the theories that goes along with aging is that part of what makes our cells age is that the processes on the inside, the cellular chemical reactions and the things that are happening, start going faster and faster and faster and faster. And you know what happens to you when you start going too fast with things, you start to make mistakes. The same thing we believe happens at the level of the cells. What the sirolimus or rapamycin does is that it taps the brakes on that process. It taps the brakes on that process and may slow down some of that accelerating mechanism, so it gives the body a chance to fix itself. And in aging cells, that may be an important thing. So this was studied and published in 2025 to be used, a little bit before usually, and this is how I started using it, 21 days before the onset of the stimulation, the egg stimulation or the IVF stimulation. I have since learned that I think there's a more plausible biological mechanism to use it a little bit earlier. And so if we have some time before we're going to start doing stimulation for IVF, then I really like to use it 6 to 8 weeks before we start that stimulation. And I kind of have my own little recipe for that. But that's called sirolimus or rapamycin. And I really do feel like that may be a better choice for folks with age-related egg quality issues. At least that's my hope, and certainly more research is needed. Again, it's still experimental, but we learn more every single day. And the follow-up question there is, what's the best diet prior to retrieval at age 40? And this is a question we get asked a lot. We get asked this a lot, and part of that is because Gosh, there is a lot of noise out there as it pertains to diet. There really is. That folks, there is a lot of noise about keto. That keto, oh, you must be doing keto. It's the only thing that you can and should do. Other people say, oh, no, not even keto. Carry that even a step further. Carry that on into carnivore. Carry it on to carnivore. Carnivore is actually really what you need. But the answer there is, Mediterranean works as well. That's the heart healthy diet, and that's the one that there's probably the most evidence behind in terms of being anti-inflammatory. And inflammation is what gets us here. So what we want in terms of diet is something that is low inflammatory. And the one thing that all these diets have in common is that they are low carb. So I think to the extent that you can monitor your carb intake, that's when you're doing yourself really the best favor. But is it Mediterranean? Is it keto? Is it carnivore? There is no evidence that one is better than the other. But high carb means high inflammation. So to the extent that you can minimize that, I think you're better off. Now, that being said, I tell people, please don't try to go on a carb-free diet, because it's unsustainable. You really can't do it. We need some carbs in our diet. We have to have them. It's important for our metabolism. But, I'm fond of saying, don't have pizza for breakfast and a birthday cake for lunch and pasta for dinner. That's an all carb diet. And that's probably something that you want to avoid. So limit carbs, but don't try to cut them out entirely. You have to be able to live sensibly. My 2 cents worth there. Hi to Kayla and hey to Aaron. Good evening, Safety Beast. Hi to Nikki and to Fraley. Glad to see you here. Joe Beatrice, nice to see you. Hi, Pooey, up in the St. Louis area. Looking forward to seeing you next month. V. Reese, good evening to you. Logan, the therapist. I am happy, as always, to see you here on a Tuesday night from Northwest Arkansas. Great to see you. Mohi Amal, good evening, Amal. Amal says, I have a day 5 embryo that came back chaotic after PGT, and this is my only embryo left. So let's talk about that term, chaotic. A chaotic embryo is not a reflection of your life before retrieval, nor is it any sort of indicator about your personality. A chaotic embryo just means that there are so many abnormalities with it that it is almost to the point of being comical, which means that, well, you know what? In fact, it may not even be real. And in many cases, when you rebiopsy a chaotic embryo, you find out that that embryo is normal. So most laboratories, PGT laboratories, will offer resequencing of a chaotic embryo at no additional cost. Not all of them, but most of them do. Now, that does mean that your embryo has to be rethawed. It has to be rebiopsied. And remember what's happening when we biopsy an embryo. We're not taking a piece of the baby. We're taking a portion of the embryo that will become the placenta. So the embryo looks something like this. The baby parts are on the inside. And what they're doing is they're taking a few cells from the outside part of the embryo. That's called the trophectoderm. And that's what becomes the becomes the placenta. That's where we do that PGT testing from. Your practice, Amal, may charge you for the biopsy because it does require work, pretty extensive and highly technical work on the part of the embryologist to do it. But oftentimes, the laboratory itself will not charge you for resequencing that new biopsy that gets sent. And as I said, in many cases, the chaotic embryo was just so ridiculously abnormal that it can't possibly be real. And so think of it, that's why they call it chaotic when you do rebiopsy it. Oftentimes it does end up to be, or in many cases, it turns out to be something that's normal. So especially I would consider rebiopsying the embryo because then you'll know. Now, the other consideration is it worth just going ahead instead of rebiopsying the embryo? Should you just transfer the embryo? You've got one embryo there, right? So, technically speaking, do you need to spend money to get the lab to tell you whether it's normal or not? The truth is, if you put that one embryo in you as an embryo transfer, it's either going to stick because it's normal or it's not because it's not. So you may just consider transferring that embryo instead of rebiopsying. Now, there is a scenario where we would say, don't feel super comfortable doing that. And that scenario is if those chromosomal abnormalities involve chromosome 13, chromosome 18, or chromosome 21. 13, 18, and 21 can create situations where you may actually get an implantation and an ongoing pregnancy from an embryo that is not going to be compatible with life on the outside, or that may result, let's say, in the birth of a baby with Down syndrome. Not that that is the end of the world. Down syndrome kids are very sweet, but that may, and having a special needs child is to many people is a blessing, because these are wonderful, still wonderful people, but that may not be what your heart has in mind for you if you're going through the process. So 13, 18, and 21, those are embryos that we are usually a little hesitant to think about wanting to transfer if the results from that chaotic embryo include those chromosomes. So something to think about there. Hi, Emily. Good to see you here this evening over on the Instagram side there. Let's see. We've got Gradle. Hi, Gradle. T. Andre, hi, is that Tara? I hope it is. It's great to see you. And Caston X is here as well. So I got another question that came in to me before the program here. And the question is asking about an endometrial polyp. What is... Oh, it is Tara. Thank you. Hi, it's great to see you. What is an endometrial polyp and how does it stand in the way? An endometrial polyp is a fleshy-like growth that arises from the endometrium or the lining of the uterus. Sometimes this polyp can stick up like a tree trunk. It can hang down like an icicle. It can sometimes be a little flat thing on the top there. But basically what it is that it's an abnormality in the uterine lining. And so it suggests that there was something that went awry with the receptors for the hormone. So imagine it this way. Your uterine lining, your endometrium, is like a little city block with a bunch of little houses on it. And every little house has a TV antenna on top. That TV antenna is receiving the signal. In this case, it's receiving the signal from hormone, and that signal is telling it to either grow, or in some cases to stop growing, and maybe even to slough off. Well, if it's receiving the estrogen signal that's saying to grow, since there's one TV antenna on top of every house, the lawns in those yards are growing evenly. But imagine what happens on one of those little houses when instead of just one antenna, there are 15 antennas, right? It's receiving too much signal from the television, so it may blow out the electricity in the house. Well, in this situation, since it's receiving the signal from estrogen, that signal is saying to grow. And so instead of growing a nice, normal, even lawn, what it's done is that it has grown a patch of weeds. It's grown one little area of the yard that maybe the neighbor's dogs particularly loved, and it made it grow all like big in that one place. Well, that means that that particular patch of yard does not have the same capacity to implant an embryo the way the rest of your endometrial yard does. And that's why we go in and we want to identify and remove a polyp. So a polyp sticks up there. Think of it as like a windshield wiper. It can knock your embryo right out of Dodge. More importantly, it's just really representing a chemical abnormality in the receptors for hormone. And those receptors for hormone are what makes that lining receptive and hospitable to implanting your pregnancy. So what is a polyp? It's a growth of weeds. And what do? We want to remove it. How do we do that? Well, we have a little camera. That camera is called a hysteroscope. And the procedure is called a hysteroscopy or a hysteroscopy. Hystero means uterus, scope is to look inside. So it's a little camera that goes through the cervix. The cervix, you remember, is a tunnel that leads to the inside of the uterine cavity. So we can place a little camera up on the inside. If there's a polyp there, we have a little instrument that can either, like maybe a little pair of scissors that might just go and remove the polyp. Sometimes it's like a little Pac-Man. It goes and it eats the polyp. We can remove it. We can do the same thing with a fibroid. We can do the same thing with some scar tissue. We can do the same thing with bands of muscle. So in my practice, I like to be able to look inside the uterine lining before we do something that's going to try to get you pregnant, because we want to know that that uterine cavity is normal. I've seen many a case where that step is skipped and people go on to do some treatment options only to then find out later that there was a polyp or a growth or something on the inside. And they say, oh, I wish that I had just done that beforehand. And I say, yeah, I wish you had too. So we strongly recommend that you do evaluate the uterine cavity before placing an embryo on the inside or before trying to get pregnant. Now, we talk about a polyp. A polyp is a fleshy growth. A fibroid is literally a ball of muscle. The uterus itself is made of muscle. And this muscle is a smooth muscle, but if you think about the muscle of your bicep, these muscles come together in these nice little sheets, and these sheets form a little hollow organ that is the uterus. Now, the job of that muscle is to squeeze the baby out when that time comes, right? But sometimes as these sheets of muscle are coming together, one of the little cells gets knocked off, and that ends up forming a ball. And that's what a fibroid is. Now, 70% of women, 7 out of 10 women, have some fibroids in the uterine wall. And most of the time, they don't matter at all. And 70% of people, if 70% of people have fibroids, then you can be assured that the presence of a fibroid itself is not necessarily problematic. Many times these fibroids are very small. They may be 1 or 2 centimeters. They may just kind of sit within the wall of the uterus or sit on the outside portion of the uterus. And those types of fibroids usually don't cause issues. Now, sometimes people will have very large fibroids, or will have a great many fibroids. And when there's a great many fibroids, what they do, they used to call them fibroid tumors, and they're really not tumors because they're not cancerous. They're a benign growth. But these fibroids, they start to develop their own blood supply. And so they can alter the blood supply that's going to the rest of the uterus. And that may result in things like having very heavy periods, very heavy menstrual bleeding. You may find also that having those fibroids can create a bulk type symptom. And the bulk symptoms are, gosh, this feeling that you can't get your pants buttoned because, increasing abdominal girth. You may find that this fibroid is sitting on top of your bladder and making you feel like you have to pee all the time. You may find that the fibroid is getting in the way and creating pain with sexual relations or sometimes with a bowel movement. Fibroids can cause all of these problems, but in most people, fibroids don't cause symptoms at all. We start to consider that when a fibroid is above about 5 centimeters in size, that it may begin to cause problems with pregnancy. The best evidence shows us that fibroids that are less than 5 centimeters within the wall of the uterus, or really, for the most part, any fibroid that is sitting on the outside part of the uterus is not likely to be a big problem. But fibroids can also be inside that uterine cavity, and those are called submucosal fibroids or an intracavitary fibroid. And intracavitary fibroids absolutely take up valuable real estate that your baby wants to use in order to implant and grow. So not only can they cause irregular bleeding, but they can cause issues with getting pregnant and staying pregnant. So in that scenario, we like to see those fibroids disappear. We like to see them gone. Those little submucosal fibroids are things that can now be taken care of through minimally invasive surgery, really very, very easily. So it used to be a situation where if you were going to go remove a fibroid like that from inside the uterine cavity, there was an instrument that sort of was like a little bit like an electric razor. It had a little wire on it, and it would literally carve out pieces of the fibroid, and it would create these pieces that floated around the uterine cavity. We call them chips. And you'd have to keep carving out and then clearing the chips and carving out and clearing the chips. And this could go on and on and on for hours. Sometimes these surgeries got to be really very lengthy and challenging to your patients. Not to mention the fact that all that fluid that's going in with the hysteroscope could potentially put you at risk because you do absorb some of that fluid. Well, nowadays we have an instrument that is very, very elegant. Things that used to take, could take hours trying to remove a fibroid now can be done in really just a few minutes. There's an instrument that's called a MyoSure, and it's again very, very elegant thing. It kind of works like a Pac-Man. It does make that noise. And just literally removes the fibroid right before your very eyes. Takes a little bit of skill to learn how to use it, but once you do, it is a wonderful, wonderful tool to be able to have in your armamentarium. Hi to Kelly and Ashley and Erica this evening. We are going to be running out of time tonight, but you know what? Every week at the same time, we come here for Fertility with Fink and Friends because I am Fink and you are friends. And every Tuesday at 5 o'clock Central Time, we get together to do all these things that are important. Let me answer your questions next week. Would you throw them my way? But remember, next week is a special presentation we're having in honor of Pride Month, where we will talk about some LGBTQ plus options for those who are interested and be able to answer all questions. New Life Fertility, where I'm a fertility gynecologist here in Pensacola, Florida, will have a booth at Pensacola Pride Week on Pensacola Beach. By the way, if you've never been to Pensacola Beach, it is a wonderful place to visit. Please do that. And while you're in town, come and see me here at New Life. I also work with MCRM. That's the Missouri Center for Reproductive Medicine in St. Louis, also with office in Tulsa. I go to both those places, and I hope that one place or another, I'll get to meet you face to face. Remember, this fertility stuff is not the book of your life. It is only a chapter. And what are we here to do? We are here to rewrite that chapter together. Every step forward with love and every step forward with kindness. We talked about that at the Fuzzies with Fink. Please do something kind for your neighbor. smile at a stranger, random acts of kindness are really what keep this world moving forward at a time that's so challenging. And it seems like there's never enough good news out there. And every step forward with hope, because tomorrow is a new day, my friend, a new day indeed, and it is full of all new adventures. So until next week, I'm Dr. Randy Fink. Thanks so much for being here, and good night.